At this point, I would like to turn the intro over to Sari Schumann, who is going to finalize the rest of the intro and guide us through the rest of the hour here today. So welcome, Sari.
Thanks, Steve. Welcome to the webinar today, everyone, on early screening for dementia for people with intellectual and developmental disabilities. In this webinar series, the Administration for Community Living's National Alzheimer's and Dementia Resource Center has partnered with the American Society on Aging. We're pleased to have all of you in attendance today. Before introducing our speakers and beginning the presentation, Erin Long from the Administration for Community Living will provide a brief welcome.
Hi, everyone. I just wanted to take a minute to thank you for taking the time out of your day to join us for our webinar. We're very excited to have two great experts in the area of dementia and people with intellectual and developmental disabilities, one being Sandy Fournier, who is a grantee of ACL, and the other being Kathleen Bishop. We thank them for being so generous with their expertise, and back to you, Sari.
Thanks, Erin. As Erin mentioned, today we're hearing from Sandy Fournier and Kathy Bishop about methods and techniques related to early screening for dementia for people with intellectual and developmental disabilities. Sandy has a master's level nurse, certified in developmental disability nursing, and as a brain injury specialist. She has more than 20 years of experience with the intellectual and developmental disability population in a variety of roles, including nursing and administration. In addition to being the project director of the Administration for Community Living Grant for Specialized Supportive Services at Seven Hills, Rhode Island, she is the Long-Term Services and Support Oversight Manager at Neighborhood Health Plan of Rhode Island. Dr. Kathleen Bishop has more than 40 years of experience in the developmental disabilities field and more than 20 years as a gerontologist with a specialty in aging with developmental disabilities. Dr. Bishop works as a consultant for many organizations in the aging and intellectual and developmental disabilities networks to assist with program and support and planning. She also teaches online courses at Utica College on aging with disabilities. I'm going to turn the floor over to Sandy at this time for the presentation, and we will do questions at the end. Sandy?
Thanks, Sari. I want to thank you all for joining us today, taking time out of your busy schedules for this really important topic. I do want to start with some background on Alzheimer's, and then we'll talk about Down syndrome, and then kind of how they mesh together and start talking about assessments. So Alzheimer's disease was first identified in 1907 after a German physician studied a 51-year-old woman with what is now recognized as the classic memory loss, disorientation, and hallucination. He found what is similar in description to the plaques and tangles commonly associated today with Alzheimer's disease when he did postmortem studies. That was 110 years ago, and we're still talking about it today. So today, more than 5 million people are affected. This number continues to increase as our life expectancy grows as well. 70% live at home with family, which increases stressors both emotionally and financially. Family and friends who are caregivers often need to either reduce or eliminate their work outside the home, causing less available funds, and are sometimes also paying for some of the needs of the individuals with Alzheimer's, causing that much more of a burden, and I'm air quoting here, calling it a burden because it truly is beneficial to the person. But that burden results in increased rates of depression, and studies also show a greater propensity to other chronic illnesses for the caregivers. This slide represents the millions of people in the United States and the projections into year 2050. As the population gets older, so do the numbers of individuals with Alzheimer's and related dementias. This slide talks about the various forms of dementia. Although we're discussing Alzheimer's type dementia today, it's important to recognize that there are other types of dementia caused by other factors. The importance of a differential diagnosis is critical, as some types of dementia are very treatable while others are not. As you can see on the slide, I know the writing is kind of small, but not only is Alzheimer's disease shown there, vascular dementia, Parkinson's disease can result in dementia, frontotemporal dementia, and then dementia with Lewy bodies are also things that need to be considered in that differential diagnosis. So a quick review of the symptoms of dementia. Again, these can be caused by other conditions, so the importance of ruling out other causes is critical. It's not one symptom, it's multiple deficits in memory, communication, and executive functioning. I recall one of the first presentations that I had gone to, it was sponsored by the Alzheimer's Association of Rhode Island, and the presenter said, it's not the fact that you can't find the keys to your car, it's you're not knowing what to do with the keys when you get to the car. And I think that sums it up pretty well from what I've seen. So now a little bit about Down syndrome. Down's is caused by an extra 21st chromosome, so it's a genetic disorder. The three different types are trisomy, which is the most common, mosaic Down syndrome, when some cells with 3 copies of chromosome 21, but other cells only have the usual 2 copies, and translocation Down syndrome, which happens when a person has 2 copies of chromosome 21 plus an extra part of a chromosome or a whole extra chromosome. The last two, the translocation and the mosaic Downs, are less common. So typically we are accustomed to the trisomy 21. There are classic characteristics that are recognizable in many individuals who have a diagnosis of Down syndrome. The facial features are prevalent: the flattened nose, the smaller mouth, the almond-shaped eyes with the slant up, a tongue that may stick out of the mouth. Often there are tiny white spots on the iris, the colored part of the eye, a shorter neck, small hands and feet. They also may have a single line across the center of the palm of the hand, or small pinky fingers that curve towards the thumb. Now, most babies with Down syndrome will have these characteristics, but definitely not all. And a little more about Down. Studies have shown that greater than 70% of those with Down syndrome who are 65 and older have Alzheimer's disease. As is typical with all people, the longer an individual lives, the greater the chances of developing Alzheimer's. With the better care that folks are getting in the community, people with Downs are living into their 60s and 70s. I actually have had one individual with Downs live to the age of 79 years old, which is really impressive and really says a lot for the care that the gentleman received. Autopsies of younger individuals who have a diagnosis of Down syndrome have shown that significant levels of plaques and tangles can be found in the brain by the age of 40. Although the life expectancy of individuals with Downs is increasing, the incidence of developing younger onset Alzheimer's is greater than older onset. We've found that the plaques and tangles tend to occur earlier, but they don't always show the symptoms as they occur. Especially for the person who has Downs, we need to be aware of changes that are exhibited. The early signs tend to be less often found with memory loss and forgetfulness, and more often we see changes in overall functions such as reduced interest in interacting with others, less interest in usual activities, an increase in distractibility and irritability, sadness, and even aggression when that is not usual for that person. We may also see sleep disturbances, changes in coordination, excitability, and seizures. Researchers have not yet discovered what the patterns tend to be different among those with and without Down syndrome. So a little bit about that differential diagnosis that I spoke about earlier. Now that we have a basic understanding of Alzheimer's and Down syndrome in the intersection of the two, let's discuss obtaining a diagnosis once we've identified the possibility. This slide shows a typical approach to differential diagnosis using patient history, a history of symptoms, looking at a family history, emotional status, living environment, and of course the physical exam and lab tests, the neuropsych testing, memory testing, language skills evaluations, and other executive brain function testing. It's always important to obtain an MRI, CT, or X-rays to rule out other potential causes or symptoms. But when we're talking about individuals with developmental disabilities, we are faced with some barriers to the correct diagnosing. These barriers to early diagnosis, there are definitely barriers to early diagnosis with everyone, family and friends often contribute the early signs of Alzheimer's as part of the normal aging process, the individual's social skills may continue to be intact, often hiding what's really going on. The patients themselves will deny that anything is changing and will not seek medical attention. They may be embarrassed, they may be ashamed. Of course, the lack of one definitive screening tool or test is often a barrier. Some patients will be reluctant to participate in the various screenings because of the lack of anything definitive that results from each test. So, in addition to the barriers mentioned for routine diagnosis, let's consider some of the additional hindrances to a differential diagnosis with individuals with intellectual and developmental disabilities. Due to a sometimes disruptive transition process at various times of life, a detailed patient history may not be available or may not be complete. Although we do tend to have a number of staff who stay employed providing services to the same individuals throughout the years, in general, the industry of intellectual and developmental disability care has a high staff turnover rate. This can result in a historical perspective of the person's personality, likes, dislikes, and things like that not being well known to the staff, making it difficult to recognize the loss of interest in things. Sometimes families aren't closely involved, so obtaining a family history can be difficult. The assessment of emotional status and a living environment can be clouded by systems issues involving other individuals who are living in the same environment. So there is not a common understanding among medical practitioners about the best practices to work with populations with differing needs. There still exists a propensity among some practitioners to attribute the changes that are seen to the overall diagnosis of Down syndrome, a practice known as diagnostic overshadowing. The neuropsych testing is often targeted for populations who do not have an intellectual or developmental disability, so the responses are inaccurate as they don't necessarily apply to life experiences to the person with the disability. Oftentimes, the memory and language skills are also not appropriate to an individual that had some limitations prior to developing Alzheimer's. Compliance issues with testing are compounded by facilities not having the available resources to allow for extra time that a test may take. So in comes the role of health advocacy for all of us. Because of these barriers to diagnosis, the role of health advocacy is paramount. As professionals in this field, it's the job of every one of us to promote health literacy to families and to staff. We need to identify opportunities to educate caregivers on the importance of reporting all changes and encourage open and honest team discussions. When speaking with medical providers, we can't be afraid to ask questions, obtain answers, and discuss the plan for testing to help guide them. The second half of today's presentation, Kathy Bishop will be discussing the NTG-EDSD tool. We've used that tool with one agency in Rhode Island that has incorporated the tool into annual assessments of every individual that's supported in both day and residential supports. Staff training regarding Alzheimer's and related dementias is ongoing and begins with new staff during the stage of their orientation period. They began their approach by identifying individuals who they thought, and again I'm using air quotes, would benefit from the approaches, and then expanded it to be more routine to include all individuals. Paired with the NTG-EDSD tool, they incorporated a stress survey tool, reinforcement surveys that include exercise, recreation, and solitary activities, peer inventories, and a recording of the client. This recording serves not only as a strategy of support in the event of dementia, but as a baseline to the point in the client's life so as to compare or recognize any decline should other signs and symptoms appear. At this point, I'd like to also add a little bit more about health advocacy. It comes in many forms. In addition to advocating for the person among the medical community, it's important to keep the person as the paramount subject. Keep the person engaged to their fullest extent. Exercise, therapies, and activities remain important. Things like favorite music, pictures of people and places that are familiar or that may bring back memories, pet therapy, spiritual therapy, structure can help the person to feel comfort in their being. Different things will work different days, but the importance of a structured day activity, sameness in schedule, is critical. This can be difficult when providing care for others as well. I recognize that. Another important support to include is that of the caregivers, the families, friends, and the staff that are providing the care. The use of support groups, time off, reasonable schedules also need to be considered. To summarize my talk, the increase of Alzheimer's disease represents a challenge to the field, compounded by what has been found to be under or misdiagnosis. Early identification of disease allows more thoughtful and thorough planning for the future, less of a reactive approach. By providing the necessary interventions, services, and supports, it allows the best chance to ensure a good quality of life coupled with quality care. As one of my co-workers would say, the right care at the right time in the right place. And that ends my presentation. Again, I'd like to thank you all for joining. If you have questions, I will be around at the end, but you can also contact me at the contact information that is on the slide. Thank you, and it's all yours, Kathy.
Thank you, Sandy. Excellent, and thank you for turning it over. I do want to make one correction. This is Kathleen Bishop. I am not the co-chair of the NTG, the National Task Group on ID and Dementia Care. I am the co-chair of the Task Group, Group T, which is the Training Curriculum Development Committee and the Training Committee. That honor goes to Dr. Matt Jansky and Dr. Seth Keller. They are the co-chairs. Let's talk about this, the objectives. We want to look at the steps of healthcare advocacy to go into more detail of what Sandy has done an excellent job of presenting. Discuss the process of conducting quality observations for healthcare advocacy. Understand that while caregivers are not responsible for the assessment and diagnosis, their input is absolutely essential for an accurate, helpful diagnosis and intervention. Understand that healthcare advocacy within the screening and diagnostic process by caregivers, which includes family advocates and clinicians, is essential. Why do we want healthcare advocacy for all of us across the lifespan, and especially for adults with IDD? And it's because we all need to have healthcare advocacy, and especially when we're discussing the disease of a type of dementia, in particular Alzheimer's disease, as we're discussing today. Sandy mentioned that it's been 170 years since it was labeled and recognized, and yet here we are 107 years later that we really can still not definitively diagnose this disease to the point where we can say that without a doubt we are sure this is what the person has before the person has died. I don't know if there's any other cadre of diseases that have been known certainly that long that would still not have a way to diagnose or a way to prevent. It's important to understand there are often interventions that make a difference in quality of life and health. This is true for all of us, and this is also true for adults with IDD. Staff and family are the experts about individuals with ID, and it's important to recognize that current changes and symptoms, they know the person across the lifespan, so they become the best resource. They also know what changes have happened. It is also important for all of us to understand that healthcare is an art, not a science. It is one that we work together with healthcare providers to make a difference together as in an art. It's an art using skills that are developed and using experience across a lifetime, combining that with knowledge and information as best as we can. For people with IDD, advocates need to help speak for an adult with dementia because their cognitive impairment can become a barrier to self-advocacy. And this may be especially true for people with IDD who may not have the experience, may not have the verbal communication that others may understand more easily, especially healthcare providers who do not know them in the same way that family clinicians and other advocates do. There also is an ageism in our society in general, even though we don't want to admit that there are isms that exist. This is one that still does. If you don't believe it, go on any comedy show, late night show, and when there is a joke about age, it is one of the jokes that people rarely become offended from because it is so ingrained and accepted. This is especially true for adults with IDD. As they become older, they are compounded by myths and stereotypes that can get in the way of an accurate diagnosis and appropriate interventions. Providers may assume that there will be automatic losses, declines in functioning as part of aging, and they may also assume that the diagnosis is dementia, especially if the person has a pre-existing diagnosis of Down syndrome, because there are misperceptions that, based on some legitimate science, some earlier science that has changed as we've learned more over time, with the assumption that it's inevitable, there is a higher percentage of potential for earlier onset for adults with ID to be diagnosed and show symptoms of Alzheimer's disease, but it is not 100%, and yet there are many providers out there that still may believe that it's 100%. The importance of ruling out treatable conditions, this is true especially for all older people. It is very rare that an older person goes into a healthcare provider's office presenting with just one symptom that then points to just one possible underlying cause. It is essential that we figure out what the underlying cause or causes are, and again, most often it is a number of causes. And through the process of differential diagnosis that Sandy just discussed with you, it is important to go through and rule out the likely causes through assessment and then interventions. And in a minute I will get to the tool that Dr. Lucy Ezralou and her committee on the NTG developed. We also want to do this because all of us have the potential for the highest possible quality of life and functioning in our later years, and it is essential that all of us are given this opportunity, and this is one of the ways that we can use the best time in terms of working with our healthcare providers to make quality decisions on assessment, screening, and on the process of providing intervention to determine what it is that may be happening. Sandy discussed the process of differential diagnosis. All of us deserve to have this process, especially when we have ongoing symptoms that we can't figure out what the underlying cause or causes may be. It is essential, and especially essential in the process of determining the type of dementia. Dementia, of course, being an umbrella term that covers many, many diseases and underlying causes that appear as a cadre of symptoms, usually significant memory loss, significant functioning, and difficulties with functioning as the person has functioned over the lifetime. For people with IDD, by diagnosis criteria, they are already challenged in some of the areas of functioning, which to a healthcare provider who does not know the person may assume that that is loss rather than the person's level of functioning. And this is where the healthcare advocates, who should include family, clinicians, direct support staff, and other advocates, as well as the individual themselves, to speak for themselves to help the healthcare provider go through this process of ruling out, matching those signs and symptoms, figuring out possible underlying causes, and then ruling those out. These are some of the common conditions: stroke, side effects of medications, nutritional deficits and imbalances, alcohol and drug abuse, dehydration, cardiovascular disease, environmental challenges, environments that do not meet the needs of the people using them, sensory impairments, depression, Lyme disease, normal pressure hydrocephalus. Understand that these are common conditions for older people in general when they exhibit a loss of functioning, a decline in cognitive capacity that should be looked at and ruled out, because these are common conditions in the general population For each person with IDD, there will be a different risk factor and for these, which will go back to what Sandy talked about, knowing the medical history, knowing the family medical history as much as possible, so you can use those as clues as to direct you to what it is you should be looking for in terms of screening, assessment, and then potential intervention. There are 4 steps of healthcare advocacy: to observe, to report, prepare for the health appointment, and then follow up after the appointment. In observation, it is essential to look for changes in the person. And so are there personality changes? And of course, we display our personality by our behaviors, by the way we interact with others. Are there changes in that? Are there activity level changes? People do not wake up in the morning and say, let's see, I will make everybody around me unhappy because I'm going to refuse to go to my day activity today. People do not do that. It's something they've always loved to do. This is a clue, a change, and this is the kind of clue that unless you are assisting in the healthcare process, you as in whatever capacity of advocacy, you need to be helping that healthcare provider understand those clues to know that this is a change in behavior and can help lead us to determining what it is that may be causing this cognitive or functioning decline or behavioral change. And the observation should occur in the context of the person's social and physical environment, because there can be clues, there can be certain times of the day, certain environments that there is increased difficulty in functioning or a significant change in behavior. And so it's important that we have observed those clues, and then we look for in those observations what it is that may be relevant. It may be a clue that needs to be reported. So we're going to want to report in a systemic way by the time that we get to the healthcare provider's appointment. Unexpected memory problems, difficulty performing usual tasks, again, compared to who that person has been throughout the lifetime. We often in our training talk quite a bit about the life story and the essence of each person. People who are in individuals' environments have known them over a lifespan, family members in particular, direct support staff in particular, know that essence of that person. And they have a strong sense of when there are significant changes and when those changes need to be reported, observed, reported, and then looked at as some underlying causes, what's going on causing that. Getting lost or misdirected. So if the person has always gotten lost or misdirected, then that is not a clue for us. Confusion in familiar situations, changes in personality, again exhibited by our behaviors, problems with gait or walking, new seizures, or never having seizures in the past and now having seizure activity, trouble recalling recent events or recognizing people and places. It is about change from who the person has been, excuse me, throughout the lifespan. I can't emphasize that enough. Trouble finding the right words, again, is a change. Problems planning and carrying out tasks, following a recipe if they could in the past. One of the challenges for people with IDD is there may be skills that we think of that people often perform in the general population that cannot be performed by that person. And again, if the healthcare provider does not know that person, they don't know that it's been a change, that this person could never tell you what day of the week it was or who was president or what is happening in the world around. And so it's essential that the healthcare advocacy includes helping the healthcare provider in a very short period of time of understanding what the change has been from the person's original level of functioning. Trouble exercising judgment, controlling emotions, not keeping up personal care such as grooming or bathing, social withdrawal, again, all changes. Then it's essential that we report and document. And the tool that I'll show you in a minute, our screening tool, gives you the ability to be able to bring that together to have a baseline, which is something we, of course, recommend, and then look at what changes have happened and what changes are significant for the upcoming healthcare appointment. Document the observations, be accurate and specific, including if it happens certain times of the day, happens in certain settings. Look at the context of what's happening before, during, and after, and in particular to behaviors, because all behavior has meaning. And in this kind of what we're talking about is relevant. It is relevant to healthcare advocacy and understanding that this is a form of communication someone's using to help us try to figure out what is going on, trying to tell us what it is we need to know to help make a difference for quality of health and life. Report to the right person and use correct forms and process. Again, the time of day, who is present, where did it happen, how often do you observe this symptom, what was happening before and after, and making sure that there is a system and process in reporting to the right person. The right person or persons being those people who will be going on the health care appointment. Preparing for the health care appointment. This is done if there is a team and if it's done with an organization. If it's a family and the person is living with a family, and it is the family member or members that are going in the health care appointment, the team meeting would be if they're a family, others in the person's life. Maybe there are day activities the adult attends, and so it may be then talking with those, trying to gather information from people around. You're looking for those helpful clues that are going to help with that differential diagnosis to determine what the underlying cause or causes are for the changes in the decline that we're seeing. Prioritizing, always prioritizing based on life-threatening and those that are severely limiting functioning and quality of life. Preparing a checklist or form for the attending caregiver to bring to the appointment, which can be using our screening tool. Make sure the person who goes to the appointment with the individual is included in this team meeting or family meeting, able to communicate symptoms, and has some healthcare advocacy skills. All of us, by the way, have healthcare advocacy skills. It's learning to organize those skills and learning to use them and to have a voice speaking out in a partnership way. We want to be developing a partnership, working together in this art of practicing medicine to try to figure out underlying causes and to try to make a positive difference in the person's quality of health and life. And to make sure that if the individual does have a diagnosis of Alzheimer's disease, it's more likely to be a diagnosis of probable Alzheimer's disease, that we've done everything possible in the differential diagnosis to rule out and determine that this is the possible cause. The follow-up of recommendations without caregivers after the appointment, this is often where I've seen in my consulting work, where it can sometimes fall apart. There may be a few things discussed, may not all be written and sent back, may not be communicated to everyone who needs to know. And especially with geriatricians and working with older populations, it is very, very rare that there will be only one visit. In fact, it never should be with the diagnosis of Alzheimer's disease. There should be many visits and many lab and assessments, lab work and assessments conducted, because we are ruling out. We want to find what the underlying cause. And even after we feel comfortable that there has been good differential diagnosis, feel comfortable with the diagnosis of Alzheimer's disease, the healthcare advocacy doesn't stop, because there is this great potential for quality of life within the disease itself, and so that continues following up after the appointment. Regardless if we feel there's an accurate diagnosis, we want to look for a life plan. We may also have to look for specialists and others who can help us determine, especially if we're uncomfortable, that all of those possible underlying causes that can realistically be ruled out have been ruled out. What to do when a type of dementia is suspected. Use a screening tool to identify signs of dementia. If the screening instrument results are positive, refer for assessment. You can refer to an agency. Again, looking if there is an agency, if you are affiliated with an organization, especially an advocacy, an organization, and especially if it's an organization that has medical personnel, nurses, and others. And if the organizations do have these, we really should be prioritizing that these are the people who should be involved within organizations and assisting with families to make appropriate diagnosis and then interventions. A screening tool is not an assessment tool. It is an instrument that permits the recording of select data that is associated with a condition or disease. A diagnostic instrument is one that is based on valid measures that are associated with agreement on the presence of a condition. An MRI, for example, is a diagnostic instrument. It has been validated, showed to replicate the same information over time, and so it is a diagnostic instrument. The tool that I'm going to show you is a screening tool, and it was produced after approximately about a year and a half of work of Dr. Lucy Ezralou's committee, because such tools, screening tools for adults with IDD, just do not exist. A typical screening tool in the general population would be to ask the date, something significant about current events, to ask questions, to count backwards from 100, which is one I always love, because I don't think I can count backwards from 100 by threes. I'd have to take me a while, and I'd be hesitating every step of the way, having to subtract. So those are not often relevant screening tools. Those do not indicate something for someone who may not have had that level of functioning to begin with. Early detection is important because we want to rule out and treat other possible causes for the changes in the decline. By doing that, we may be restoring or coming close to restoring the person to the original level of functioning and cognitive capacity. We may be prolonging when we see more significant behaviors, more significant clues and symptoms and losses. So the earlier we can identify these losses and try to determine underlying causes. And Alzheimer's disease in particular is not a disease that acts in exclusion of other pre-existing conditions, in exclusion of other health problems. And so the secondary conditions, the other health problems, continue to be and sometimes can be exacerbated by this disease. And so it's important that we use a tool such as a screening tool not only for early detection and to try to get accurate diagnosis, but to continue to monitor the person and to continue to provide health care advocacy over the course of the disease and over the person's life. It can lead to an earlier referral and possible interventions, can help in identifying potentially treatable conditions, and that is major. For example, we know for adults with Down syndrome, there is a much higher rate of significant hearing impairments that can affect functioning. Hearing impairments affect functioning in any older adult. For adults with Down syndrome, there is an earlier onset and much increase in severity of the hearing impairment. If we can identify that, there are things we can do in the environment. We can look at hearing aids if they're appropriate. We can make sure we're communicating in well-lit areas without a lot of background noise. And so there are interventions we can provide to help that person to continue to function. If we don't address that hearing impairment, the person is likely to withdraw, become isolated, and may exhibit that. Any person with a hearing impairment may exhibit it with what we call inappropriate behaviors. Those behaviors that may be unpleasant for the person and for people around them, but are perfectly appropriate when no one is paying attention to what is going on with that person and we're not using screening tools. So we want to do this on, we want to use a screening tool that we can use as a tool that we can present to healthcare providers. And so as a result, this is what was produced by the National Task Group. It's the National Task Group Early Detection Screen for Dementia, the NTG-EDSD. I do want to mention that these are all, this is available free on the NTG website. There is also a manual for it. It has been translated into a number of languages because there is nothing like this in the world. Same thing has happened with other documents that the NTG has produced. And again, these are available free. Sandy mentioned an organization who used this detection tool. There are also hundreds of organizations and families around the country that have used this tool successfully. Early and periodic screening benefits to pick up warning signs, helpful with early differential diagnosis, easy to collect quick and impressionistic data, and a good way to start the conversation. It can also become part of the individual's permanent record or program plan to periodically track changes in behaviors. And another recommendation for families, and those of you who are sources for families, that you make sure that there is a permanent record that is available to others across the person's lifespan. The NTG tool is available to use as a digital tool. This was a request we had in training 2 years ago. That was asked if we could make it digital, actually by a family member. We did, and so this you can maintain records, including not only the screening tool. I would advise the videoing that Sandy talked about, that this is something that is done consistently over time as one of the tools. Here is a copy of the NTG-Early Detection Screen for Dementia, EDSD. The recommendation is to begin at least by the age of 40 for people with Down syndrome, and then conducted annually. For people without Down syndrome with other forms of IDD, to begin at the age of 50. You can begin earlier. These are guidelines that are used in terms of research, traditional guidelines, but certainly could have the baseline. And the earlier the baseline, the more you're going to catch a piece of information that will be so helpful as the person grows older. Here again can be used by support staff and caregivers to be able to note the presence of key behaviors associated with dementia. And it is very easy to use. I've had a number of direct support staff who've used, and family members who talk about how at first they were frightened to use it and felt they didn't have the medical information, and then realized that they do have the information and that it was helpful for them as they went to the healthcare appointment. The information gathered, all information to get a sense of who the person has been and get a baseline for that person, demographics, ratings of health, mental health, and life stressors, a review of some of the multiple domains, including activities of daily living, language and communication, sleep and wake patterns, ambulation, memory, behavior, and effect, as well as chronic health conditions. This is all needed because it gives us a full picture for the person. It helps collect basic information. That information can be used in determining what interventions, what further assessments need to be done as part of conducting that differential diagnosis. You want to make sure that you speak with family members, other staff who know the person. You include people who spend time with the person and can provide you valuable clues. You want to look through medical records, through program plans and personal files, and you try to get a consensus among, or it may be the fact that at one time of the day that there's a different observation than another time of the day. That may be relevant, needs to be captured on this as well. Again, that short digital video is also important. Use the information at the annual wellness visit or with updates as changes occur during the year. It does, the Centers for Medicare and Medicaid Services, CMS, did not recommend a specific assessment tool. Our tool has been designed specifically for people with IDD, and so would really recommend using this tool. After it's completed, you review it, talk it over with the individuals involved, and you want to take it on the appointment. You want to know those things that are priority clues, what is significant in terms of changes in functioning for that individual. There are physicians who are not familiar with the tool, but most physicians, healthcare providers, will be pleased that something has been brought in an organized manner that can be used as a tool, as a clue to try to conduct that appropriate differential diagnosis, to conduct appropriate assessments, and appropriate interventions that may be pointed out by the screening tool. Here is where the EDSD is available free. It's in 14 different languages, as I mentioned. There also now is being offered a full and partial day workshop. Again, this is all available on the website for you to go on free and to look at the resources that are there. You can make a positive difference across the lifespan for persons with intellectual and developmental disabilities through healthcare advocacy. I really encourage all of you to look at some of the tools available and to think about how each of you can make a difference. At this point, I'm turning it back to Sari.
Great. Thank you so much, Kathy and Sandy, for these helpful presentations. This is the time where we will go to our question and answer session. I have quite a few questions that have come in, so I will get right to it, but please feel free to ask additional questions if you have them, and we'll get to as many as we can. So one of the questions that came in is asking how, if either of you have suggestions for how providers can promote early diagnosis with the restrictions of Medicaid and Medicare for services that doctors are able to provide.
Sure. So this is Sandy. That is actually kind of right up my alley. They're working for a third-party insurance. Really, there are not necessarily restrictions that Medicare and private insurance have on office visits. The barrier that I've encountered most is that the physician or the nurse practitioner doesn't have the time scheduled in their day that an appointment may take because of the various reasons why appointments just take longer for this population. But I really don't know of restrictions that are in place that would limit the assessment of the person's situation.
Yeah, I don't know of any restrictions either, but it's really, I find most often, especially in New York, that there is first, could be a nurse practitioner, could be a nurse who is taking the information and gathering it, and that's where you want to start presenting the tool in that beginning of that. The physician often comes in, and so you're helping guide in beginning what needs to be focused on in that tool and introducing that tool. I know of no restrictions, however.
A few questions have come in asking if someone with IDD or Down syndrome develops dementia, is it always Alzheimer's disease, or can it be a different type of dementia? Can you talk a little bit about that, and which, if it is other dementias, which ones you sometimes may see?
Dan, do you want me to take it, or?
Yeah, that's fine, Kathy.
Okay. It is most often at this point in time diagnosed as Alzheimer's disease. However, there is even discussion because the course of the disease seems to exhibit a little bit differently, possibly more rapid than it does in the general population. We also know that the The pathology of the neurofibrillar entanglements and plaquing occurs much younger in people with Down syndrome, which seems to be, and that's related to chromosome 21. There is a much higher diagnosis of Alzheimer's disease and the symptoms that look like it for people with Down syndrome. However, there can be other types. I have seen a couple of people with Down syndrome who it actually appears to be related to Parkinsonian dementia rather than, or it can be a combination, because it can be a combination. This goes back to why it is essential to do a differential diagnosis, because there can be different treatment plans, different interventions that would be provided based on what the underlying causes are. And if I were to be totally frank, we still don't know for sure in the diagnosis. This is why we usually use the terminology probable Alzheimer's disease. And in a lot of my work, I will see either it's never written in the charts or it is written as the general term dementia rather than really telling us what the underlying causes are.
Great, thank you. Kathy, can you also talk a little bit about how one might determine the most appropriate agency or provider to conduct an assessment, evaluation, or diagnosis of a person with IDD and probable dementia?
By organization, are you talking a care organization? Are we talking health care? I would look to your local areas to see if there is anyone in the area that has experience with people with IDD, and that's rare. I would look to see, and one of the great places to start is with your Alzheimer's Association can tell you who in the area has memory clinics, may have others who can conduct an appropriate differential diagnosis. You want to make sure that it's someone who is knowledgeable, that knows that it must be a ruling out process to determine what the underlying cause, and to make sure that the person is not assuming the healthcare provider or organization does not automatically assume a type of dementia, especially in adults with Down syndrome. And so you can ask other families. There are support groups in the area that can tell you who it is that has done work in this area. There may be a medical center in the area that has this expertise. And so you can find those resources by looking to the organizations that are out there for IDD. They can help match you to those organizations that can help with this process.
Great, thank you. A few questions have come in about the NTG-EDSD tool, asking if it needs to be used in conjunction with another tool like the SLUMS or another assessment tool, and then how often is it recommended that the EDSD tool be completed?
Andy, why don't you start with that one first?
Sure. Well, the first thing I want to point out is the NTG-EDSD is a tool, not necessarily an assessment. So it is definitely not something that should be used alone. It's part of, think of it as one of the things in the toolbox to get to the right answer. So that, there are a variety of tests, but as both Kathy and I mentioned earlier, oftentimes those tests haven't been adapted to the IDD population.
And in terms of how often, I would start as soon as you know of this tool. It doesn't have to be someone who is exhibiting decline. And so I would start with doing a baseline using the tool and getting used to using that tool with your healthcare provider for the annual visits. And so I wouldn't wait to somebody, especially a person with Down syndrome, is exhibiting symptoms of loss. I would do it as a baseline and just have it as one of the tools, as Sandy said, that you have available for information. Then you would look to use it when there are significant changes. I would use it annually, and then during the year, if there's some significant changes, again, as a tool. It's only a screening tool. It is not an assessment. It's not a diagnostic process. It's a screening tool to take to your healthcare provider to show what changes have happened and to narrow down to those clues that will help give you some indication of what assessments need to be done, what further screening needs to be done to determine the underlying cause or causes.
Great, thank you. Sandy, can you talk a little bit about any support options you know of for caregivers after the person they're caring for may be diagnosed with dementia and where one might find those supports?
Absolutely. One of the models that we're utilizing is education of caregivers. It seems that caregivers just cannot learn enough. They're eager to learn. They're eager to learn those pearls of wisdom. And, obviously void of grants similar to the one that I run in other states, the Alzheimer's Association is always an amazing resource where so much of those tools can be found. The other place, and again, it's not available everywhere, is really finding out about your age and disabled resource centers that are in your state. Here in Rhode Island, it's called The Point, but every state has ADRCs. They often have a lot of resources available that caregivers can go to and pick up brochures, pick up contact information to get further support that they need.
Great, thank you.
Yes, I want to add to that, Sarah, if you don't mind. Do call the ADRCs. Every state has them. They are the Aging and Disability Resource Centers. In New York State, for example, it's called New York Connects. And call them. They may not have the answers, but you really need to be calling to let them know that they need to be looking for further resources and helping connect. People don't know there's a need, and organizations don't know there's a need unless you're calling and asking. So certainly I encourage you to call them and to be asking for assistance. Usually they can at least link you up with somebody else, but the more calls they get, the more likely there'll be a focus of trying to determine where those resources are and having those available to you.
Great, thank you. We have time for one more question. A few folks asked if the early 20s is something that you've ever heard of where a person with IDD may be showing signs of dementia or cognitive decline.
I have had one person who was in their mid-20s when it was noted, and actually was a vascular dementia that had occurred. It wasn't Alzheimer's.
Right, so
I would be very highly, highly suspicious. In fact, I'm highly suspicious when I'm asked by a family or an organization to come in and to try to help them determine what's going on and what follow-up should be done. If the person has Down syndrome and they're in their 50s and 60s and 70s, I always start out with suspicion. Because there is this great leap even in the general population that if there's cognitive decline as someone is older, then it must be a form of dementia, and there becomes not purposeful, but almost a laziness that happens, and it's not purposeful, it's related to funding and time constraints, and that we must as advocates make sure there is never that assumption for anybody, and this becomes more compounded when the person has Down syndrome. We had an excellent presentation by Dr. Brian Chacon, a webinar that the NTG did a few weeks in January, actually, to actually address this early regression. And he also, the same emphasis, you must conduct that differential diagnosis. You must determine underlying causes, and a good percentage of the time it is not a form of dementia at that point, or an Alzheimer's disease, which is what most people think of as dementia. There are a number of underlying causes, and it's just essential that never assume at any age, but even more so when someone is younger, make sure you're working with healthcare providers who conduct differential diagnosis, and make sure you're giving them tools, you're giving them the clues to help them be able to conduct that differential diagnosis.
Great.
I think, Kathy, it's also So I was just going to add that I think it's also important that if the onset is acute, if it's sudden, then we're probably not looking at dementia. And as Kathy had said, the practitioners have tended to jump right to dementia when it was a urinary tract infection, the person being on prednisone therapy, changes in blood sugars, that type of thing. That could have been could really mislead.
Yep, and this is true in the general population. I just can't emphasize that enough. But for people who may have challenges in communicating their symptoms, even more so, it becomes even a little more difficult to figure out. But it's essential. Never, ever, ever jump to a conclusion that it's dementia without doing that appropriate differential diagnosis. And even within the course of the disease, as Sandy mentioned, when it is acute, when it's happened quickly and it's severe, that is rarely the dementia or the Alzheimer's disease, that diagnosis itself. There's something else going on, as she mentioned. It's essential that we continue to treat those throughout the course of an individual's life.
Great. Thank you so much to both of you, Kathy and Sandy, for your presentations and your responses to some of the questions that came in. We're going to wrap it up now for today. Steve, did you have any closing remarks?
No, I just wanted to remind everyone that if you are participating today, you will be receiving a follow-up email with a CEU link by the end of the business day today. So just a quick note on that.
Great. Well, thanks a lot, everyone, and we'll wrap it up for today and hope to have you back on our next webinar on May 16th.
Thank you.
Thank you.